really to speak to you about obesity therapy in HFpEF, where, of course, there is quite some interesting advances. Of course, when you talk about obesity in HFpEF, I should say the very obvious thing to begin with: take the guidelines and treat your HFpEF patients, and that also means you treat the obese HFpEF patients. And the most important part is give them diuretics when they have congestion. And of course, now give them SGLT2 inhibitors. ANKER and DAPA have a 1A recommendation for obesity. And you can see basically that even in the patient profile type approach to treating patients with HFpEF that we recently published about in the European Journal of Heart Failure, the core of the therapy is SGLT2 inhibition with diuretics, but then you have all the different phenotypes around it. But one of them is obesity, and we already mentioned semaglutide and tirzepatide possibly there, and I would like to share with you some of the data why we are doing it. Of course, you're knowing that our most interesting new therapies for HFpEF come out of the diabetes world. We have the SGLT2 inhibitors. They are basically reducing blood glucose by inhibiting renal reabsorption of sugar. We have also the GLP-1 agonists. The two trials in HFpEF that really are key are the DELIVER and the EMPEROR-Preserve trial that showed overall that HFpEF patients get a benefit, and importantly, they also get this benefit in the obese subgroup. Now, some of you might argue about maybe we should use SGLT2 inhibitors specifically to treat patients with obesity. On the one hand, that is true because you get a good quality of life benefit. Here on the left, you can see that the benefit is highest in terms of change in quality of life measures. The benefit is highest in the most obese patients, but they also have the worst quality of life to begin with. So maybe there is some degree of a regression to the mean problem here. Some others of you might say, well, what about the weight change? And on the right, you can see with dapagliflozin, very similar with empagliflozin, we have a modest, at best, change in body weight, about 2.5 kilograms for patients with BMI above 40. This is not a specific obesity therapy. It's a general therapy of HFpEF that also works in obese patients. Still, we need to take care of obesity. Obesity is very frequent in HFpEF patients. So what do we do about it? And now we are coming to the GLP-1 receptor agonists. Let's start with semaglutide, where we really have most of the data. And this is just a small review of the different trials done with 2.4 milligram of semaglutide, a subcutaneous once weekly injection, and showing that in all sorts of trials, in all sorts of conditions, you get a strong weight loss. And this was the reason why then also trials in heart failure patients with a preserved ejection fraction were started. One trial is still ongoing with semaglutide, and that is the trial in diabetic patients with HFpEF. BMI above 30, ejection fraction above 45, randomized 1-to-1. Okay, we will see how this trial is going, and it looks for multiple endpoints, but body weight and quality of life are the key. With the same endpoints and a total of 529 patients, recently the STEP HFpEF without diabetes trial reported. This was shown at the ESC. It's now published this week in the New England Journal, also in print. And this is how the trial looked like: 1-to-1 randomization and 1 year of follow-up. Kansas City Cardiomyopathy Questionnaire, 8 points improvement on average. This is approximately the highest amount of improvement we see with any treatment in heart failure. Of course, it's for the subgroup of obese patients where you have really a poor quality of life to start with. If you look into the body weight, of course, this is important in obesity. The change between the groups was 10.7%. The change in the placebo group, 2.5%. The change in the treatment group, 13.3%. So this is a massive reduction in body weight. And this is also related to a 20-meter improvement in 6-minute walk test. All of this just published. Now, you might say mechanistically, what is really this treatment doing to the metabolism, to the inflammation, to the heart function? Well, for CRP, we can tell a 39% reduction of CRP. We know that inflammation plays a role in HFpEF, so maybe that's also a good thing to see in these patients. We do have a reduction that is substantial for CRP. We do also have a reduction that is substantial with anti-BNP. Now, this 16% reduction might seem to many of you not very impressive, but don't forget, the patients are losing fat tissue. Fat tissue is known to bind natriuretic peptides. So the patients with the weight loss have a more amount of fat tissue loss, so they should have less binding of anti-BNP, and so the BNP should be more in the circulation, and still we see a reduction. So this reduction is likely an underestimate of the true change in natriuretic peptides. There is also some cardiac benefits. What about safety? Well, in general, the number of serious adverse events was less in the semaglutide versus the placebo group. If you, for instance, look here at cardiac disorder side effects, a strong reduction. Cardiac events really were reduced in the patients, and you can see all sorts of other things. There is relatively little that is basically related to the problems. The only thing we see is gastrointestinal adverse events. Of course, that is part of the effect. You have a premature filling feeling, you have constipation, and this is something you might argue is actually due to the having less food intake due to the body weight reduction. Now, these metabolic effects that I describe you now from the STEP HFpEF trial are also seen in general with semaglutide in different populations of diabetic and obese patients. Reductions in hemoglobin A1C, reduction in blood pressure, reduction in CRP, and all of this associated also with reductions in lipids. And you might ask yourself, well, what about changes in cardiovascular outcomes? Well, and for this, there was a big trial where recently a press release gave us some hints. So this is all really creating a lot of optimism. 17,000 patients randomized, non-diabetic patients, BMI of 27 or higher, at least 45 years. And in this trial, for instance, and this will be very interesting, also more than 4,000 heart failure patients. I would assume mostly HFpEF patients, but we don't know that yet. We don't know. Only thing we know is there's overall a 20% reduction in MACE events. This was reported as a press release. The patients treated with semaglutide had less death, stroke, and MI in this trial. I would assume that later this year we will see all the details. Now, ultimately, is there more to come? Definitely yes. Tirzepatide is a dual receptor agonist for GIP and GLP, and you might even have a little bit more weight loss with this therapy. You can see you might even have on average 15-20% in diabetic populations with tirzepatide, as shown before. Is there a heart failure trial ongoing? Yes, there is. It's actually of a longer duration. It tries to do like a 2-year follow-up. It tries to analyze with a win ratio, death, hospitalization events, and then also quality of life changes and exercise capacity changes. And this is planned as a registration trial. We will see whether this works, but quite a number of people are optimistic. So we can basically say today that obesity therapy is possible. We have many opportunities for phenotypic approaches to the patients. The core number one is SGLT2 inhibition, but very soon, I believe, we will also have a specific anti-obesity therapies as part of it. The future is very bright. Thank you so much for your interest.